Um, and we'll start right at 1 o'clock, okay? I'm going to go through these slides. Okay. Mute ourselves because thank you. We've got a lot of things going on. So please mute us. You can do that.
Hey everyone. Greetings. Good to see your faces. Jen, you want me to kick us off?
Yes, please.
All right. So I want to welcome you all to this session today, this afternoon, for a couple hours where we're going to talk about integrating substance use disorder education into medical schools curriculum and all the related things, topics related to that. I'm Kim Nelson. I'm your SAMHSA, so that's Substance Abuse Mental Health Services Administration Regional Administrator here in Region 7. And as most of you know, that's HHS, Health and Human Services Region 7, Kansas, Iowa, Nebraska, Missouri. I know many of you on this call, but I also see some new faces, so that's wonderful. It's nice to see faces. So really our purpose here today is around kind of cultivating and making connections between faculty, students, medical schools, community-based organizations, state agencies. We have several groups of folks here joining us and really appreciate everyone's time. We're looking to identify common challenges and then strategies. What are some places doing that other places maybe don't know about that might help us move toward graduating medical professionals who understand and are able to treat substance use disorders. So that's our purpose today. And I am going to turn this over to Dr. Tony Decker to give us a little intro about COPE. Tony? Looks like you're still muted.
There we are. Okay.
There we go.
Well, greetings, everyone. I'm actually sitting in the urgent care clinic at the Gallup Indian Medical Center with the Indian Health Service. And unfortunately, I'm seeing the effects of the opioid epidemic every day. COPE is the Coalition on Physician Education and Substance Use Disorders. We've been together for several years, and most of us are academic and clinical staff. We're hoping that we can improve the educational experience and assure that all physicians, both trainees and practicing physicians, are trained to prevent, identify, provide early intervention, appropriate interventions, and then provide treatment for patients with use of tobacco, illicit drugs, and prescription drugs, and those who engage in unhealthy use. So our goal here is to really enhance the experience and try to identify educational interventions that fit each facility to maximize the impact, to have practicing physicians that are actually able to provide reasonable and effective intervention services. So the overriding goals that we have here, overarching goals, support the med student curriculum and actually graduate medical education curriculum too, in prevention, identification, treatment of substance use disorders in all specialties. And that's an important factor because both for osteopathic and allopathic training programs now, the specialty of addiction medicine is recognized by ABMS and by the AOA. And these are post-residency specialty recognitions. We want to promote the sharing of knowledge with med school faculty and students, looking at the champions that are really going to promote this, and also look at clinical practices, especially in opioid use disorders, because COVID has challenged us dramatically. It is tragic what's happening where I'm practicing right now. And the loss of communication, the loss of the sober support programs has really been a devastating blow to people who are trying to maintain their recoveries. But looking at proper opioid prescribing practices, identifying patients with opioid use disorders, and really preventing overdose events and treating the other substance use disorders that go with it, especially the stimulant use disorders. And of course, we want to advance training for medical students and to make this something that is not just a requirement, but something that is actually desired by medical students to expand their clinical acumen to improve the care that they have for their patients. And we're also including waiver training for the buprenorphine, although this may actually be something that's not going to be a requirement in the future, but we want people well trained for that. So for more information on COPE, you have the website down there, and Jennifer, who's our director, is instrumental in expanding this program. We are enthusiastic participants in working with all of you. Thank you.
I think I'm up. Is that correct, Jen?
That is correct. Lisa, there you go. Sorry.
Yeah. No, thank you. I see my name. That's my cue. Hello. And no, thank you. First of all, thank you, Jen. Thank you, COPE and SAMHSA for including me on behalf of the AAMC, which is the Association of American Medical Colleges. I'm one of the senior directors at the association and have been leading a strategic initiative to help our medical educators, our medical schools, and our teaching hospitals address opioids, addiction, and substance use disorders more broadly, as well as pain and chronic pain, and how we educate the current generation of physicians as well as the future. So been working on this for a number of years, and COPE and of course SAMHSA have both been wonderful colleagues and partners in that effort and that initiative. And I just want to express, just very briefly, just my appreciation for not just them, but for all of you who are on here, who are joining us, medical students, and of course, medical educators as well. So thank you. Thank you for the work that you're continuing to do. We've been, as I said, been working in this space for a while. We've seen a tremendous increase actually in the number of curricular attention, if you will, focused on this space. We have a publication that just came out recently that showed a 200% increase in curricular activities related to opioids and addiction at the med school level. And that's at the AAMC member medical schools. So want to, again, just express my appreciation and also ongoing support. So we are at the AAMC continue to be very engaged, interested, passionate about, and very, very much want to help support you, our medical educators, our medical students, in your efforts to improve your education, your curriculum in this space. So please don't ever hesitate to reach out. We have a number of resources and an active kind of call for curricular exemplars and models of best practices in this space. We have collections and repositories and publication venues and outlets. So I'd be happy to talk to you about that at another time. I know I have very limited time right now. So, but please, if you aren't aware of our resources that we have to support you, or the great scholarship that is being done in this space, educational scholarship, I'm happy to connect you and share more at another time. So please don't hesitate to reach out. And I look forward just to joining you and listening in on and hearing about some of the work that you all are doing, and especially also some of the barriers and challenges that you're facing, continuing to face, and particularly in light of COVID. So again, thanks for the opportunity to join you, Jen, really appreciate it. And I look forward to the afternoon.
Thank you, Lisa. I'm just thrilled that you're here, and we so appreciate the support from the AAMC. And we have our colleague from the American Association of Colleges of Osteopathic Medicine, ACOM, Tyler Sumet, here with us as well. I don't believe we're going to actually see you, Tyler, but we're ready if you can talk. I know you're in transit somewhere, so.
Well, I appreciate it. And again, I appreciate being invited to the meeting.
Oh, we get to see you. How exciting.
Yeah, I'm actually in the passenger seat, so I am being safe. And I got my seatbelt on. But life is good. We're able to multitask and get things done. And I'm excited to be here because I have a personal interest in substance use disorder. I have a strong interest in seeing more of this in the curriculum and more done. And I can tell you, through the pandemic, we've looked at the issues of substance use disorder. We've looked at the issues of telehealth. We've looked at mental health issues. And we're trying to figure out ways that we can help our schools do a better job with this. So I do appreciate Steve Wyatt and others from COPE helping us explore learning management systems and look at ways we can share. Other leaders in COPE have helped us develop curricula and other things that we share with our schools and see where they're going and what we need to do to make a difference so that we can address the issues that we know we need to address. So our GR is getting involved with telehealth issues. We're continuing to provide education to our faculty and to our comms on substance use disorders. And it is just increasing in importance and relevance, and the ways we can address this are expanding. So I'm looking forward to learning from all of you, and thank you for the invite. Thank you for the continued focus on what matters.
Thank you, Tyler. Wow, this is really inspiring to hear from our associations for the medical schools. Thank you both for being here today with us. So very briefly, I just want to give you a quick overview on how this, the next bit of our time together is going to go. And I do, before we do that, want to acknowledge that SAMHSA Region 7 encompasses the traditional land of many Native people, including but not limited to these people, and pardon me if I mispronounce their names: the Iowa, Bakoli, the Kickapoo, the Oglala Sioux, and the Oto Misuria. We are grateful to be here. Our agenda is going to go like this. We're first going to hear from our regional administrator. It's going to just remind us of why we're here and why we're talking about this. Dr. Fred Rotnick will give us a keynote next. Then we're going to hear from 2 deans of medical schools on this pressing question, and they will give us some thoughts and tips. Then we're going to have a very brief break because 3 hours on Zoom is a long time. We're going to give you a chance to get up and walk around, get some water, whatever you need to do. And then we're going to have an opportunity for you all to talk to each other for a fairly significant amount of time. And then we'll come back and hear from you. What was this like? And what do you see as our next steps in Region 7? And we'll ask you to evaluate. So that's, and we'll give you kind of instructions and a heads up on how to navigate this as we go. So Kim, I think that you are up next.
Great. Thank you. Thank you, Jennifer. All right. So again, welcome and thank you all for spending your valuable time with us today. I have some slides that have just a few highlights of data. But before we start those slides, I want to tell you just a quick story. So I'm a person who has addiction. When I was using alcohol and drugs, my drug of choice, we often hear that language, my drug of choice was, what do you have? I used whatever was in town, whatever was available. And that definitely varied. Certainly I had some preferences, but I used what I could get. I think if some of the drugs that are available today were available then, I might be one of the pieces of data that we're going to see on these slides. I might have overdosed. So while the current data is important, we can't forget that most overdose deaths involve multiple substances, and those substances are ever changing. So from the 70s, we had heroin. In the 80s, we had crack. In the 90s, we had club drugs and cocaine. And, today and in the future, we have various synthetics. This will continue. Today, I'm a person in long-term recovery. So as of November 6th of this year, I'll have 30 years in recovery. So I'm celebrating all year long. I just want to say, I just say these things so that we don't forget, this data, every data point on here is a person. And that if people can get the help they need, like I have, and the continued help, we recover. So I'm especially grateful that you're here. I'm especially grateful for what you do that helps get that possibility of recovery into reality for folks. So, okay, on to the slides. So just in case there are people from other parts of the country, here's a map. There's a regional administrator in every part of the country. So there's some contact information, and maybe some of you know those folks. Next slide. I'm going to go through these slides quickly because we don't have too much time. We can talk about this information the rest of the day and or anytime you want to. So mental illness and substance use disorders in America, SAMHSA does the National Survey on Drug Use and Health each year. This is the data from that survey. It's the most recent data. It shows what it has shown for a long time. About 8% of folks 18 and above have a substance use disorder. Depends. If you go down in age, that number grows. And an ever-growing over 20% of people have a mental illness. And then in the middle there, about 4% of people have both. Importantly to note, in this year's data, we saw almost a 6% increase of people who have substance use or mental health disorders. And that increase this year was comprised entirely of people with mental illness. And one last note about this is pre-pandemic data. So what we know, as has been said, since the pandemic, those numbers just keep growing. All right, so we can't, yes, next slide, thanks, Jen. We can't talk about the opioid overdose epidemic in this region without also talking about kind of a co-epidemic of suicide. So nationally, we have seen, dramatic increases in suicide. And again, this was pre-pandemic. The CDC reported over 25, so half of the states in our country reported a 30% increase in the rate of suicides over the last 15 years. Especially important in this region because Kansas was number 5 in the nation in increases in suicide rates. So Kansas had a 45% increase in suicide rates during that period. All right, next slide. So speaking of Kansas, just a little bit of data, a couple data points from each of the states in this region. In Kansas, you can see here the kind of the main drugs of choice for treatment admissions. At the bottom line, we have opioids, the middle line is alcohol, and the top line is amphetamines. So unprecedented, more people in Kansas are showing up into treatment with amphetamines as their primary drug of choice, even more than alcohol. That has never happened. Alcohol always leads this procession. So this is important data for us to understand. Next slide. Just briefly, from 2018 to 2019, Kansas saw a doubling of deaths involving stimulants, the highest number that they've ever seen of people dying involved with psychostimulants involved. Next slide. Well, this just shows the different areas of Kansas. So from the densely settled kind of rural frontier areas to the urban areas, you can see the numbers vary widely, 833 to 36. But when we do adjustment and we look at the rates, again, of deaths attributed to psychostimulants, we can see that those rates are much less varied. So this is, we have this concern across the state. Next slide. So this is just a few snapshots of Iowa data, Iowa deaths involving opioids. So unfortunately, a tragic milestone kind of has occurred in Iowa. In 2017, they had their highest rate of deaths related to opioid. And now here we are, in 2021, their 2020 data has exceeded that number. You can see from 206 to 208. Important to understand, this is data that will increase as the lag kind of comes in, medical examiners and coroners reporting data. So that's not a good situation. Next slide. Iowa had been very focused, and still is, on psychostimulants, deaths related to psychostimulants, because they've seen a doubling in the deaths with psychostimulant involved. That number, and on the next slide, that number had, go ahead, thanks. That number had started to outpace the deaths related to opioids. You can see the bottom 2 lines converging there. Since this analysis, so the 2020 data is showing an increase again in opioids. Continued increases in psychostimulants, but opioids have kind of overtaken that second spot after alcohol. That's the top line. Okay, next slide. So in Nebraska, just drawing your attention to the right-hand side of this, that little graphic, we can see an ever increasing, from calendar year, this data is 18, 19, 20, of overdose deaths in Nebraska. And then on the next slide, Nebraska treatment admissions. I think this is a little busy, but kind of the message here, top line message would be the rates related to alcohol and methamphetamine are very similar. That's the yellow and the blue. And then the rates that are alcohol with a secondary drug, that's the kind of checkered pattern, continuous. That is a trend that seems to be continuing in Nebraska. All right, next slide is Missouri. And here, importantly, Missouri is kind of moving away from calling this an opioid crisis to a poisoning crisis. And that's for a couple reasons, not the least of which is when people think opioid crisis, they found that folks were still thinking of the orange pill bottles, and that's not really what's happening any longer. Also, the poisoning crisis, includes the psychostimulants that are, Missouri, like other states, is continuing to see, overdose deaths. So really what's leading to deaths is the highly potent, unpredictable drug supply dominated by fentanyl and other synthetic opioids. So I think the last bullet is particularly important in Missouri. Racial disparities are increasing. Black men are now significantly more likely to die than any other group at a rate of 4 times the general population. In Missouri, they're ranked 3rd in terms of overdose rates for Black people. So particular attention paid to that in Missouri. And the last couple slides, this is just, marijuana, so this was the marijuana kind of trends, marijuana use for people 12 and over in our region. You can see that Kansas and Missouri a couple years ago saw statistically significant increases in this. And if we go to the next slide, the most recent data shows all of our states, including Nebraska and Iowa now, seeing a statistically significant increase in people 12 years old and older using marijuana. Clearly, a major component here that we're concerned about are those young people and their developing brains with marijuana use. All right, so that's the quick down and dirty on the data. There's my contact information. I'm sure you all have that, but just in case you don't. Now, I'd like to introduce our keynote speaker. I get the privilege of doing that. So Dr. Fred Rotnick is a professor and director of community medicine and the program director of the Addiction Medicine Fellowship at St. Louis University School of Medicine. His clinical practices currently include addiction medicine and correctional healthcare. Board certified in family medicine and addiction medicine, he is the medical director for Assisted Recovery Centers of America, we just call that ARCA. Personally, there are a few people I call on when I need to know what's happening on the ground in Missouri and especially in St. Louis. Fred is one of those probably 2 people. He has many accomplishments, but for me, one of those really important ones is that he successfully championed and started the first non-psychiatry addiction medicine fellowship program in our region, followed closely by Nebraska. But he continues to be a strong voice in the fight to reduce stigma, increase compassion, and access to care, both at the national and international level for people who have substance use disorders. I give you Dr. Fred Rotnick.
Well, thank you so much, Kim. It is a delight working with you, and we have had great opportunities to build together, and I know there's no end to that. And I want to say a special thank you for inviting me to speak today to you. Next slide, please. An overview of St. Louis U. If you're not familiar with us, we've been around a long time. We entered our third century of being a couple years ago. We are an academic research institution with an academic medical center and with robust health sciences programs and centers for interprofessional ed. We are a large medical school with over 180 students in each class. We have over 600 faculty physicians and over 600 residents, subspecialty, and fellows in over 60 programs. Next slide, please. I'm going to talk a little bit about today of both the vertical and horizontal building we're doing at St. Louis U when it comes to addiction medicine. The vertical I'll touch on is the different levels of training that we have. The horizontal will really highlight some of our key partnerships we have in the community. I'm director of community medicine before it was, well, I still am, but before it was program of the Addiction Medicine Fellowship. So I love to be out in the community, in the neighborhoods, in the shelters, in the jails and juvenile detention facilities. And for me, this work is a unique opportunity to really bridge that community academic partnership. So today, my department chair and dean, Dr. Christine Jacobs, will be talking about integrating this work into the undergraduate medical education curriculum. But what I'm going to talk about is especially those intersections with community at both an undergraduate and a graduate level. So next slide, please. Our first course we have for the first year students in clinical interviewing just this year, we had them as part of a critical reflection assignment on their own reach out to a mutual support group, gave them some starting points, but they all engaged in a meeting with a critical reflection as a result of that, because we've integrated that into our first year clinical interviewing class. Fourth year electives for undergraduate medical ed. We have students that do electives at Assisted Recovery Centers of America, in Synergy, which is another private practice in St. Louis that does this work. This month, we have our very first physician assistant student doing an elective in addiction medicine, which is a combination of these two practices and a few others in our community. And another important undergraduate intersection is for particularly first year and rising fourth year med students are participating in the week-long summer immersion for medical students program that the Hazelden Betty Ford Foundation sponsors every year. For the last 5 years, we have had anywhere from 2 to 5 students participate in this immersive experience. Next slide, please. This slide is one of our 2 family medicine residency programs. This was the new and improved version of the program I attended as a resident in St. Louis. And when this program started, not quite a decade ago, it was started off initially as an integrated primary care, behavioral health, and very quickly a substance use disorder training program with another particular emphasis on urban underserved populations. There's a little more flexibility in graduate medical education for the didactics than we have in undergraduate medical ed, but the program has been started from the beginning with this intent on training family medicine physicians. All of the residents are waiver trained, either by me or by my fellow. In their first month, they have appointments integrated into their schedule to work with folks with substance use disorder from their very first month of residency on. Our community partners, where our residents will spend some of their elective and core time in their second and third years, includes the Queen of Peace Center for pregnant women and their children with substance use disorders, our county jail, and soon I'm sure it'll be the city juvenile detention center as well, where I'm medical director now, ARCA and in Synergy. And at ARCA, our residents as well as our fellows have been able to be engaged in our new street outreach program, which I'll mention again in a little bit. Community experiences include working with MONET, or Missouri Network for Opioid Reform and Recovery, where residents are working with harm reduction techniques, working with people who come into the center and educating them around syringe access and OEND, opioid education, and Narcan delivery and distribution. Next slide, please. Something very exciting is one of our divisions in our department is medical family therapy, which is education in family therapy that is geared towards medical settings. We have both a master's level and a doctoral level program. And these programs is one of the key principles we've done at St. Louis U with introducing substance use disorder materials. I like to call it don't add courses, insinuate yourself into existing courses. This past year, well, actually we're in our second year right now, of a HRSA opioid workforce expansion program grant. And what we are doing, particularly with that grant, is having students in graduate studies in medical family therapy, psychology, and social work have field placement training experiences in agencies with patients in interprofessional programs, and also having those same teams take place on classroom learning. One of my projects for this weekend is modifying 2 sessions we'll have coming up again this semester, where we will do 2 special interprofessional education Zoom sessions, where we will have everyone from addiction fellows, grad students in these programs, our nurses at ARCA, our peer specialists from the community, working on skill sets around communication skills, towards learning how to work about, from, and with each other in this field. Next slide, please. Our Addiction Medicine Fellowship, which Kim already mentioned, we're very excited to be the first program in Missouri. This was one of those things, it's like, okay, we have just got to figure out how to make it happen. I know Rachel Winograd and Dr. Angeline Stanislaus are on the meeting today. Were instrumental in getting us funding for our first year fellow. We have funding for the current and next 2 years, the Missouri Foundation for Health, for what I believe is the only program in the country that has core rotations in family medicine, psychiatry, and maternal fetal medicine. Again, the emphasis here is that even that's where the fellows are learning and doing their rotation. The real role of the fellow is helping patients connect to community resources for continuity of care. Also, the wonderful thing about Addiction Medicine Fellows, from the beginning, our goal has been for fellows to be culture changers and game changers in our systems. In other words, how to sneakily get those messages in there that everyone needs to participate in this kind of care. Because if we don't help our patients with substance use disorder and mental health issues, we're never going to get any of the other health outcomes we need when working with our patients. So it's time to break down the silos and do the work together. Next slide, please. As I mentioned, these are some of our core pieces. For these fellowships, you have to have a minimum of a half day of continuity clinic, meaning you're at the same site for half day a week. Our program, we have at least 1 day a week, and those continuity sites are either at ARCA or at the WISH Center, which is working with pregnant women and postpartum women and their infants and families who have substance use disorders. So it's an exciting opportunity, again, for community academic partnership. Next slide, please. Fellowship, the projects that we have that are electives are listed here. Of course, never start a fellowship during a pandemic. I learned that the hard way. Rule of thumb, don't do it. We're doing okay though. We're making it happen. We hope to establish partnerships very soon with our methadone clinic at our local VA. And we're starting now, and this is crazy exciting, to work with the SLU abdominal transplant team. Transplant surgeons have never traditionally treated folks with medication for post-transplant. Well, we know why most people get liver transplants in the United States is from alcohol use disorder. Well, we're starting to find a place at the table for addiction medicine and addiction medicine fellows in this treatment. Next slide, please. Just a photo to see where our first fellow on the left, Kate Osman, was doing street outreach with Aaron Laxton, our social worker at ARCA, literally going to the streets to do harm reduction, but also to actually do treatment. Aaron was running to the pharmacy 1 month supply at a time of medications for opioid use disorder. We were able to transition all of our patients to our downtown office before the camps were dismantled this winter. Next slide. Here are our fellows and where they are. I'm sure you'll be getting these slides at the end of today. 2 fellows starting in July. We have our city doc, again, a mid-career specialist in internal medicine, taking a year off to do this training. Hopefully, Kim will be able to travel to St. Louis or vice versa and meet people this time. And our other fellow from a rural hospital in Eastern Missouri, OBGYN, who's going to, during this year, work with her home hospital to set up a homegrown program to do OBGYN addiction medicine. Next slide. This is the end of my presentation, but if taking a look at here are our partners and our institutional support we have for this work. My next slide, please, has my email address and links to our fellowship. So please, you know where I live now. You all know Kim. Kim knows me. Anything I can do to help anyone on the meeting today, if there's things I can share from the experience so you don't have to learn the hard way how to do this work, please do so, because this is an exciting opportunity to build from disruption. That's one bright thing that COVID has brought us. So thank you very much for your time today, and I'll be hanging out with us the rest of the session.
Thank you so much, Fred. This is great. We have time for maybe one or two quick questions if we wanted to just chat for a second. I see there's one question in the chat from Doug Burgess. Doug, do you want to unmute yourself and just ask that?
Yeah, sure. I'm happy to. Hey, Fred, it's good to see
Yeah.
you and
Hey,
talk
Doug.
with you. Hey, I wanted to ask, can you talk a little bit about the administrative support that goes? I mean, you guys are doing really impressive things there, and it can be a little bit intimidating to see all this. I'm just kind of curious, what do you think is necessary in order to implement? How much administrative support do you have? Who else is involved in this? Or maybe you're just a superhuman.
No, I'm not. I would say it's.
I know you
Michelle.
are, but maybe more than I think, maybe more than I realized.
No, I'm not going to steal Chris Jacobs' thunder, who's going to talk about how to find place in the curriculum for this. But here's the way I would say to go after administrative support. This kind of work, though I know it sounds pedestrian, it checks off a lot of boxes that the LCME and the ACGME requires us to have in medical training. If doing this work, we're touching on substance use disorder, we're touching on mental health, we're touching on social structural determinants of health. If you can get a dean to say, yeah, run with scissors, talk to course directors, see where you can fit this work in, you're helping the institution and you're also getting your agenda worked in there. The other piece that's exciting is finding people in the community who want to support this work and are willing to trust you to provide the structure for the community engagement and the community connections in this work. That's where my work in correctional healthcare and homeless work really helped me fit in, because I could say to partners, hey, we're trying to grow this at SLU. Would you have a medical student hang out with you for a couple half days? Would you like to have a resident work with you for 2 days for their community medicine month? It's that kind of stuff where, as you know, Doug, building the enthusiasm around this is really, in today's world, how you can get a lot of the iceberg moving with curriculum and also with engagement.
Awesome, thank you.
I'm going to welcome Dr. Bud Isaacson, who's going to transition into this next section for us.
Thanks, Jen. And Fred, that was terrific, really inspiring work.
Thank you.
So next slide. So I actually sit as Executive Dean of Cleveland Clinic Learner College of Medicine. We're part of Case Western Reserve University, but I've been in different roles. I've been in this role for about 3 years, but I was the Dean for our curricular program prior to this. And so I wanted to share some insights really for people who are starting out and say, how in the devil do I get this type of material into a curriculum? So next slide. So the challenges are pretty daunting, but I do believe there are solutions. So I want to leave you with optimism today. But we know that there's an ever rapidly expanding core knowledge, skills, and attitudes for medical students to ingest. And, you know, most of what we learn in medical school is outdated in a matter of years. And so the proliferation of knowledge and information and overflow is not going to stop. There's also fixed curricular time, right? So how do you fit more into a fixed amount of time? And then to some extent, not with this crowd, obviously, but to some extent, you find people who may have negative attitudes about addiction and just have a sense that it doesn't belong on the same level as other things like heart disease or diabetes. Next slide. So let's step back. These challenges I would view as opportunities, and I'll share some of my perspective, and then Chris is going to go into some at St. Louis University as well. What I would suggest, and I've done here, is to look at what's the academic mission of your organization. So that to the extent you can align yourself and show, as Fred was saying, that you're actually providing solutions for some of the challenges that your academic enterprise faces, that will ingratiate you with leadership. So, in our place, care of patients, care of community is important, and research and scholarship. And I think if you can come when you have a seat at the table or have a chance for your elevator speech with evidence, as we've heard from Kim already today, of the importance of addiction medicine and how it aligns with the academic mission, that can get your foot in the door. Next slide. Then it's worth, I think, doing a little background work and finding out who the Freds are at your institution, who the Chris Jacobs are, and look for advocates and sponsors. Okay, find out who might be part of organizations outside the institution, some of the addiction specialty organizations. Reach out to the people who provide addiction treatment at your institution, who may have some advice for you, but get to know them. And then I think, as we heard from Lisa and Tyler, and I would include Cope, find advocates outside your organization. There's a rule of thumb we're all aware of, that people who come from outside your organization and say the same thing that you may say internally often are given a higher status. So we're happy to, I think by the end of today, you'll view Cope and others as a resource for you. We're here to help you if you need help in your local environment. Try to find out who some of the decision makers are, what are the different committees that even hold sway over different parts of the curriculum where you might want to get involved. In our case, we break it down through basic science, research, and clinical education. And then seek out opportunities to get involved. So volunteer, get involved on task forces, committees, anything you can do. So reaching out with an email, letting someone know that you're interested in participating, that you enjoy teaching. If you're not involved already, get involved with teaching students. I know we have some medical students on the meeting today too. Medical students can be great advocates, and so partnering with them can be terrific. What I found in my career was there was such a void of knowledge in this area that you could become a relative expert relatively quickly. And so volunteering to get out and give grand rounds, give seminars, journal clubs, whatever the opportunities are in your local environment, your clinical department, you can somehow generate some enthusiasm and inform people about the scope of the problem and get them excited about being involved. Next slide. A couple things I think are really important, and Fred, I think, mentioned that you try to sort of insinuate yourself in rather than asking to bolt on and add a lot of time. So people in position of leadership don't really appreciate as much when someone comes to them telling them there's a problem and asking them to solve it, versus having you go to someone with an opportunity and a solution. So if you can come to someone, outline the problem that's affecting the community that aligns with the mission, and have some idea of potential solutions, that will go a long way. I would not focus on time. Time is, if you look at barriers, is one of the top ones people will name. And so if you ask for a set amount of hours, that's your starting point, and looking to insinuate yourself in the curriculum, you're going to be met with a lot of resistance. Focus instead, I would say, on learning objectives, that we need to help our students and trainees learn about certain skills, knowledge, and attitudes that will help them take care of the problem. And then look for opportunities for integration, again, rather than addition. As one of my colleagues says, don't try to boil the ocean, right? So don't start by trying to do everything at once. Think about small pilot projects, a small rotation here, getting yourself involved in a small way. See what you can learn from that to bridge success to a bigger project. And as I mentioned, Student advocates are absolutely fantastic. So anytime in my career when we've gotten students involved, their passion, energy always leads to better outcomes. And so it's a great way for students to be involved. They often have a little bit more discretionary time to take on projects and do some of the background work as well. So next slide. I thought I'd just give you a couple general ideas using some things that we've done in our own medical school. And we've used this model not just for addiction. We're actually in the process at our school doing some work on climate change using a very similar model. So we have PBL, or problem-based learning. For those of you who have problem-based learning or case-based learning, I would say these are great opportunities because most of these cases have learning objectives, and you can just merely add one learning objective without changing the whole case. You don't have to blow up anything in the curriculum. If there's a lecture or seminar, adding one slide with information related to addiction medicine. If your curriculum includes journal clubs where you're teaching students how to analyze and interpret the literature, sometimes the content involved is somewhat discretionary. So if you have a chance to volunteer to lead a journal club or be influential in some way, pick an article on addiction. Pick a Sentinel article on addiction. Show through role modeling how addiction medicine has some great research like other areas in medicine. In terms of then some of the clinical training, we've have communication skills as every school does. It starts in the first year. We have a 2-year course and we integrate screening skills into that. Our clinical rotations include behavioral change counseling. We have a psychiatry clerkship that includes rotations in addiction. Primary care focuses on screening, motivational interviewing. We have OSCEs that have included addiction cases. So again, small ways you can sort of integrate addiction, substance use disorders into already existing structures. Next slide. So we do have 3 communication skill sessions in our curriculum that include addiction. And again, if you look at these, they aren't all labeled as addiction. They're labeled as screening for alcohol and other drug use. They're labeled as motivational interviewing, and so on and so forth. We have a longitudinal clerkship in our 3rd year where students spend 12 weeks doing all their outpatient integrated rotations, and we focus on screening and counseling. And we have defined skills lists. That's another thing that can help is in terms of accountability and seeing if you're achieving your goals. We have skills lists for all our students each year that then culminates in things like OSCEs, where you can actually have a checklist and see how students are performing around specific areas like smoking or alcohol use. Next slide. We've integrated addiction into our basic science curriculum because we have a psychiatry and behavioral health organ system block, and we include addiction cases and the pharmacology around addiction. And our core clerkships include additional screening and counseling. Now, as 3rd year students, we're expecting a little bit more of them. And psychiatry includes seminars on addiction as a disease, and we also have all students rotating on an addiction unit. Next slide. So just to end, what I would say is look at your own situation, identify the opportunities really. Where can you fit addiction medicine, substance use disorder education into the priorities of your academic health center? Get involved is number 1, and reach out for help. You know, bringing people in from the outside to give a grand rounds, to sponsor you in some way can really elevate your status within your own institution and help you get some credibility and make some traction. So I am really looking forward to meeting all of you in the breakout groups and learning more about what you're doing and learning from you, and also seeing how we can help you as COPE members. So I'll turn it over to Chris.
Hello, I'm Dr. Chris Jacobs, and I'm the acting dean of the School of Medicine at St. Louis University. And I'm so glad to be with you here today. That happens to be the same school as Fred Rotnick. So if you can switch to the next slide, please. So I think that one of the most important things that made us successful is presenting a compelling case. Why is it so important for us to find time and space in our curriculum for addiction and treatment of addiction? And one of the first things that any medical school is concerned with is accreditation requirements. So demonstrating that we can fill those are key. And then making sure that our physician workforce is ready. So we need to be producing doctors who not only know how to identify and treat diseases, but to respond to the needs of society. And I think medical students today are really interested in that in a way that maybe they weren't years ago. Next, they need to understand the factors that impact health, the social determinants of health, and how people engage with their health care. And then thirdly, we want to make sure that the clinicians themselves are compassionate, resilient, and engaged, and addressing these issues is a help in that direction. Next slide, please. So Fred touched on this a little bit. We have, in our school, as in many, we have two different opportunities you could think of. One is in undergraduate medical education with the medical students, and the second in graduate medical education. And Fred covered a little bit of the graduate part with residency training and our medical family therapy and addiction fellowship. But what I want to focus in now is how we did undergraduate medical education with really two major components that all of the students participate in, one being a longitudinal course and the other being an interprofessional team seminar. Next slide. So how do we go about doing this? Well, one of the most important things that you've already heard a bit today is involving people at all different levels. So getting both junior faculty and senior faculty on curriculum committees helps a great deal. In many medical schools, it's the curriculum committee that really makes the decision. And so if you have someone on that committee, they can be there as a voice, speaking up consistently. So for us in 2016, around the same time as the beginning of the addiction medicine fellowship, Dr. Rotnick, and with the support of our department, approached the dean and of undergraduate medical curriculum. And so what we decided to do was to build a longitudinal course. And now you've had the theme 3 times, which is don't add, but insinuate. And the most important thing was to get from the curriculum committee the support to address the course directors all across the continuum. You know, in most schools, there are some departments that drink the Kool-Aid, so to speak, and others don't. And so if you can start from the curriculum committee or the associate dean of undergraduate medical education, then you can really make some strides in that direction. And one of the real carrots that we offered in our school was the ability to check off boxes for the LCME. The school had some difficulty with their accreditation, and this was a gift really to help with that. And then also, many schools now are moving to active learning, and substance use disorder education is something that is a topic that really requires active learning. And active learning is a very compelling way to talk about substance use disorders. So it goes along very well with the change in education styles that we're seeing in medical school now. Next slide, please. So we had a longitudinal course in pain, substance use, and responsible prescribing that went throughout the 4 years of medical school. And the content was also mapped to the LCME keywords and the hot topics that are used on the USMLE exams, step 1 and step 2. Next slide, please. So the methods that we used for that course were lectures, which were primarily in the lectures with active classroom learning in the M1 year when the students were learning clinical interviewing, and then lectures that were spaced throughout the other 3 years, the behavioral health, and then in our family medicine clerkship, we have 1 day where the students focus on didactics, and in the M4 capstone. Next, please. So what kind of content did we put into each of these experiences? Well, in M1, we started with the basics, interviewing questions, documentation, learning about different types of pain, learning about the public health impact of substance use disorders and risky use. And then the second year of structured classroom experiences included brain structure and chemistry, more about substance use disorders and co-occurring mental illness, theories of change and motivational interviewing, classes of substances, intoxication, withdrawal states, all of those topics. Then as the medical students move into the M3 year, they start to learn the public impact of substance use disorders and start to learn about medications that they see when they're traveling around in their clerkships, and also Narcan and overdose education. And then into M4, we refine that as they learn more about how to interview patients regarding their pain and their function at a higher level, and actually to prescribe analgesics responsibly. Next slide. We also have, in addition to this 4 years of maybe you would say structured longitudinal education for medical students, we do have the Center for Interprofessional Education. And in this, our family medicine department takes a lot of leadership as faculty and small group facilitators and course speakers. Next slide. So what happens in this seminar, which has been going on since 2008, is that there are 7 different disciplines, including medical students, allied health students, nursing students, physical therapy, medical trainers, and they all come together in a large lecture forum. Of course, it's a little different now with COVID, but they have a case presentation and discussion, and then they break up into small groups. And in this course, they practice their communication skills. They work in small groups with each other and discuss the patients and learn how to accept the contributions of the other members of the team. And these are courses that occur about 6 times a year for a few hours. And there's some faculty development associated with it. So one of the keys is to get the buy-in from faculty. It turns out that in most schools, if alongside of the medical school, there's a nursing school and allied health school, they're very happy to collaborate because interprofessional education is such an important part of healthcare at this point. Next slide, please. So I mentioned that we talk about a patient in these seminars, and we make sure that each year, at least one of the patient cases is regarding substance use disorder. So for example, in 2021, we used a case from Washington State University of a 65-year-old man who had substance use disorder after he'd been chronically prescribed opioids. And the participants, all of these students, got to practice their screening tools, the DAST and the PHQ and the PEG. And then they also get to practice at simulated rounds, speaking about these patients, as well as a simulated interprofessional meeting. And these seminars then prepare them for their clinical experiences later on. Next slide. And so those are all required classes for the students, we found that some students really want to dig deeply into community issues as well as addiction. And so we began a urban community health track for students who really wanted to take care of urban underserved patients. It was sponsored by the Department of Family Medicine, and students had to apply to be part of the program. It has a focus on service, on rotating in areas or having clinical experiences in FQHCs and areas that take care of underserved patients. Some of the service opportunities they have are at the Recovery Centers of America, Recovery House, Archway Institute. And throughout this, they are mentored by faculty and have very intense discussions that have to do with their experiences in these environments, and they learn quite a bit about addiction medicine as well as the other social determinants of health in these small group sessions. Next slide. So in sum, what I would say, and having just heard about first what Fred mentioned about some of our curriculum and Dr. Isaacson, and then continuing on that, the idea of looking for little niches, little nooks and crannies into which you can insert addiction medicine, and also demonstrating to the larger institution the value of the curriculum will ensure your success. So with that, I will close.
Thank you so much, Dr. Jacobs and Dr. Isaacson. Those were fabulous things. We have a couple minutes if we wanted, again, if folks have a question or two we could talk about now, that would be just lovely.
I want to acknowledge Lisa put a very relevant comment in the chat box, I think, about the fact that we're moving away from just time as a measure in the curriculum to competency-based outcomes, and that's very, very true. And I love the idea of really trying to meet the needs of the accreditation through substance use education, because it really touches on so many areas. And we've seen so much recently with COVID and disparities and other social determinants of health, and it all intersects with this area in a very relevant way.
Hey, this is Daniel Orrin in Wichita. I appreciate the presentation.
Excuse me, Dan, could you raise your volume?
Oh, yeah, I'm probably wrong. All right, there you go. Can you hear me better?
Yes.
Yeah, cool. Wrong. I'm on the microphone on the closed laptop. That doesn't work very well. I'm looking at trying to get students interested in addiction medicine, and I'm curious how other places have facilitated that. One of the thoughts I had was trying to start up an addiction medicine interest group. We've got interest groups for everything under the sun, and addiction medicine is not included. So I'm curious if you all had advice on getting students interested, and if so, how you manage that.
I mean, I'll take a crack. I think, Dan, that's a great idea. Interest groups, again, I'm thinking about what's relevant in your community. Certainly, in Northeast Ohio, where I'm at in Cleveland, we're seeing the ravages of the opioid epidemic like everyone else. And our institution has actually taken that up as a challenge to be out in the community doing more work. So if you can sort of fit it in with a community activity and say who wants to be involved, and it becomes something highly relevant, not just in a silo, but really making an impact in the community. And I think I have found students to be incredibly enthusiastic. And if you put out a call early on saying who wants to get involved, just to have a meeting and learn more about this and see what we can do for the community, almost always you get some uptake.
And one way to introduce it is to have a seminar on addictions or a lunch talk through one of the other interest groups, like the family medicine interest group or primary care interest group, and see how many students show up. And if you get a lot of students, then you know you have that core group. The issue with interest group is you need to make sure that you have a faculty who can help them through the years, because I'm sure you know that with all these interest groups, one year you have enthusiastic students and the next year not so much, and then it kind of swings wildly unless you have a faculty who can help you with that continuity through the years.
Wonderful. Do we have anybody else who'd like to ask a question now? We can always get your questions later and follow up if you're still processing and thinking.
Well, I could speak to just adding on to Dr. Warren's statement there. My interest in addiction medicine wasn't peaked until residency, when I did the professionals in residency program at Hazelden Betty Ford, which my program at the University of Nebraska Medical Center did, which had I been exposed to that earlier through their medical student programs, then I would have shown I would have found how much passion I had for that and maybe been involved in more of the student groups. Whereas even a student group in med school, I wouldn't have gone to because I had no knowledge of my interest in that just yet. So I think earlier exposure to set experiences will probably generate and drum up the most interest among the students, more so than, well, I mean, I think the group is necessary to keep that going, to keep that enthusiasm and career direction momentum. But unless you're exposed to it, you just don't know. And I would never have known if it wasn't for that experience at Hazelden. So looking into programs like that, I think is the best thing, at least in my personal experience.
Thank you, AJ. Great advice and tip from your own experience, which is often the most powerful. Okay. Anyone else? Curious, just very quickly, I know we have some students on. Students, do you have a question or a comment to close this out, since this is really about you?
Sure. I'm a student at St. Louis University. Hi, everyone. Thank you for the invite, Dr. Rotnick. Kind of to add to that last comment, I can say from my experience, I'm an M1, so I have a long ways to go, but going into medical school, I knew that I wanted to pursue something related to mental health and longitudinal patient care. So my interest in addiction medicine actually began last semester when I met kind of Dr. Rotnick, and through our clinical interviewing course, but through psychiatry interest group. So I do think that psychiatry and substance abuse and substance related disorders, they go hand in hand and they intersect so much. So now I have the privilege of being the lead for psychiatry interest group this year. So what I'm going to take away from this talk is how can I kind of incorporate or weave in issues related to substance abuse disorders and kind of weave that into my interest group this year. So there's my comment. Thank you again.
Thank you, Samantha. Inspiring, just really great to hear from you. You're the best source for this kind of intel. We can make things up, but we don't know for sure. So thank you very much. Okay, I don't see anybody's hands up or anything, so I'm going to shift gears. If you could put this into the chat, that would be great. Then we'll be able to share those ideas with you. You will receive a copy of, or you will receive the recording and the slides, which will be included. So that will be a follow-up for us from you. So just really quickly, especially to the students who are here, I'm hoping that you've already heard about COPE's Medical Student Curriculum Challenge, where we are seeking innovative learning and teaching about substance use, opioid use disorders in the medical school curriculum. So building on what Bud said earlier, students are often the best, or usually the best, at creating curriculum ideas that mirror what it is they want to learn and how they want to learn it. So what COPE is hoping to do as part of our work under the Opioid Response Network, which are all these graphics that you see on these slides, we're funded through the AAAP. We are looking for medical students, individuals or in teams who have a faculty mentor who create a curricular design, simply a lesson plan or a unit design. So either a one-shot lesson or a more comprehensive series of lessons that fit together into a unit that will support the learning of medical students in this arena. And you can see right there what that's about. So we're looking for topics focused on these areas and others that we may not have thought of or haven't mentioned. So we're really hoping to receive some kind of novel instructional strategies. We know that there's been a great deal of advances in the cognitive sciences lately that show really how people learn the best. And many of our teaching strategies now in UME are not particularly aligned with those. So we're hoping to see that students say, this is how I know I learn, and this is what I would like it to look like. Or technological innovation or unique assessment or unique assessment types. So we're going to go through the applications that we receive, which all the information's available there on copenow.org under the Medical Student Curriculum Challenge tab. And the 10 applications that fully meet our criteria will receive a remuneration of those amounts in support of their time. And then what COPE will do is take those designs and produce them, make them available freely to folks, to schools around the country and beyond. I just got a message saying that you're not seeing what I am seeing. I'm sorry, I think I forgot to share. I beg your pardon. Thank you, Cami, for getting me back on track. Let me share that and just, so you got to watch me reading. That must not have been particularly interesting. Thank you, Cami. So here's the overview of what I just said. And this again will be in your slides. Regrettably, our submission deadline at this point is in 2 weeks. So we will completely understand. Oh, Kim, thank you. I see it was you that alerted me. Thank you so much. It takes a village. We do have a deadline for March 15th. We will be taking a look at that and seeing how robust our application pool is at that time. So that could change. However, if the students who are present would like to apply and would like some more information, please contact me, Jen at copenow.org, and I'd be happy to either talk with you, answer your questions, or get you motivated. I'm hoping that you have spring break somewhere in there before March 15th, if you get such a thing. Do I see Fred shaking his head? No spring break? Yep, okay. Well, if you have a great idea, I would encourage you to not let perfection be the enemy of the good and to submit what you have. So there, and I'll be, like I said, I'll be available for questions after that. So actually, are there any quick clarifying questions before we go to our break? be happy to take those. I'm not going to stop sharing my screen because I'm kind of scared to do that now. So any questions from folks? Let me check in the, see in the chat, see if anybody has a question. Or if you just want to unmute yourself and ask, that would be just fine. Oh, there. Yes, I see. Sorry, Kim, I missed your message. Okay, so hearing none and seeing none, seeing no questions, I do really hope that we can capture your really valuable ideas, students, and motivated faculty. So if there are folks here who are thinking of a potential student, if you can take this idea back with you and see if you can stimulate some interest in this, that would be terrific. Thank you so much. So, deep breath. What a lot of wonderful information we've been exposed to this morning or this evening. So we're going to take a brief stretch break. And when you come back, we're going to say in 8 minutes, we will, I'll give you the overview on how the small groups are going to work, and we'll put you in groups to talk to each other. Okay? So I'll see you then in 8 minutes. Not our first, but we are learning how all of this works. So
No worries. I think it was user error. I think I hit the button and I meant to do something else. So apologies to my group for leaving in mid-sentence.
So are we all back again? I guess we are. Very good. Well, Jen, do you want me to just start the debrief? Okay.
Yes, please. You might want to introduce yourself since I don't think you've had that opportunity yet.
So I'm Dr. Steve White. I'm an addiction psychiatrist and in Charlotte, North Carolina. So that's where I'm talking to you from, and have been involved in addiction medicine education, addiction psychiatry education for many years, and I'm an original member of COPE and have been a part of many of these regional meetings in the past. So I'm now going to help facilitate the debriefing that will include hopefully discussions, because like you're going to hear, we had somewhat of a unique group that I was just in, but there's different people obviously in all the different groups and all different backgrounds. And so if we could have the facilitator. Is that how we're going to do it, Jen? That the facilitator will be giving the briefing of their section, or the medical student?
Either one, facilitator or the
Okay.
would be fine. Yeah.
Well, someone then from the first group could give us a little insight into how the group went and different thoughts that came out of the group that you feel you would like to share. That would be great.
Sure. So I can share. I'm the medical student from Group 1. So we talked about a number of different aspects around the challenges and the strengths of integrating addiction medicine into curriculum. And I think one of the big strengths that kind of several of us kind of all hit on was this idea that the best way to approach this is to find different windows in the curricula that exist in order to give kind of as many students as we can a taste of what this area of medicine is like, whether that's through, presentations at student interest groups, or getting everyone to rotate through the addiction clinic for a day on their psychiatry rotation, or things like that, which can kind of expose a lot of people so that you can kind of inspire the people that might be drawn to explore this further as part of their career. So I think that's sort of something that we found to be successful. I think the big challenge is finding those places, finding where in our curriculum we can integrate this, especially in the preclinical side. It's hard. Our curriculum structures are built up and they are what they are. And finding material that's both that we can integrate into the curriculum that's flexible but is high quality, and also that's engaging to students too, to be able to make it attractive so that people will continue to be interested in it. And so I think going forward into our need for support, I think we all kind of agreed that having events like this where we can connect different institutions together and share sort of curriculum development ideas is one of the best ways that we can go forward. That's something that these bigger organizations can help facilitate, to be able to help institutions work together to be able to do that and overcome some of those challenges. And in terms of an action step going forward, we ran out of time a little bit at the end on that, but we were kind of thinking directly moving forward with some of these things, with seeking out more easy opportunities within our curriculum to be able to present these things and continue connecting with other institutions to be able to share those high quality resources.
Mm-hmm. And Andrew, in your school, is there an interest group, or is there an opportunity? Do you have that opportunity?
Yeah, I think we do have some. We have some different interest groups that maybe. I think this is actually something that we're working on. I know I'm pursuing neurology. I think this is something that we're working on for our neurology interest group right now. And I know there's other interest groups at our school, and so I think it's a great opportunity.
Right. Very good. Anyone else from the first group that would like to say anything?
No, Andrew did a fantastic job. Since our facilitator did not appear, Andrew did a great job of describing and facilitating. So he did awesome. Okay.
Very good. Well, I was in the second group, and Nader, would you like to give a little bit, and I can fill in? So I know I'm putting you on the spot a bit, but.
Sure, I can do that. I've also put it in the group chat. So we talked about some of the successes is over the past 10 years, there's been increasing awareness of substance use disorder, reduction in stigma. Some of the challenges is retention of engagement in students and finding faculty champions. So most here, we talked about how we were preaching to the choir, where all of us here are engaged, but there's a lot of institutions that might be missing within this area. And so finding these faculty champions who can build the curricula that are needed for substance use. And then need for support. I know probably COPE and SAMHSA has probably connections in every city or where there's a medical school with organizations working in addiction, substance use. So connecting these organizations with the medical school and having more engagement with students is probably somewhere that we could use support. And then an action step we talked about is as I said, recruiting these faculty champions. And Kim had mentioned that there's quarterly meetings or so, so inviting those individuals to those meetings and building a community so that we can build these effective curricula.
Can I
Great.
jump in?
Yes, absolutely.
So I just want to put a plug in. Thank you, Nader. That's exact. I want to put a plug in for our kind of quarterly medical school and addiction medicine champion convening that we facilitate in this region. So if anyone is not on that list and we just come together for an hour once a quarter and talk about this among, the champions in the region. So anyone, and that could be anyone. It's medical schools, it's doctor champions, it's people from the state addiction policy, it's community-based providers, it's anyone who wants to help in this area. So if anyone is interested in being part of that and you're not, send me an email. I'll put my email in the chat. Okay, thanks. Thanks, Nader, for that plug.
So very good. The only other piece that I would bring up is we did talk a little bit about two things. One was possibly bringing in people that with lived experience that can be helpful in engaging students and helping them understand sort of the bigger picture and the difficulties that people can experience and different ways in which they can potentially get drawn into alcohol and other drug use problems. And then the last would be just thinking about the importance of looking at ways in which the curriculum could kind of fill out the needs of other areas, and that would be around instructional facilities or instructional ideas around interviewing and those sorts of things that can be used in all areas of medicine, but can be very helpful in obviously drawing out substance use problems. So very good. Group 3.
Yeah, I was in that group and we didn't have a facilitator or a scribe. So I took that over and I followed the directions, because I always say follow the directions on the easy stuff, get in trouble for the good stuff. So I picked some top examples based on what we're to report out. I put them in the chat box. Successes, one of the schools' willingness for students to engage, some really good interprofessional training with counseling students who learn their role by learning the criteria and being the standardized patients for the medical students to work with, which is great because we do similar things at St. Louis U. Gives people a chance to practice screening tools, SBIRT, and how to use your words, how to talk to people when you know what. I know that Nader is probably thinking, Samantha thinking this or that they're in class again, but you know what you're going to say up here, but by the time it comes out here, it doesn't always gel. Failures. One of the folks in the group talked about when they tried to train up an FQHC that did residency training, they did not have the mental health support they needed in a rural site for that to really be effective. And that's a real challenge, is bringing in some of the behavioral health and psychiatry services that are needed. So they said that that's something they're learning from, and now they're going to figure out how to maybe incorporate telehealth for psychiatry for some of the patients with more serious co-occurring mental illness. I love this. What could COPE or SAMHSA do to move these efforts forward? I know this is a little bias on my part. We do a lot of training, and a lot of materials. What if for people in practice who really want to be champions, we found ways to fund immersive experiences for 1 to 2 week intensives for people who want to do this work but can't do a year of fellowship. Put some of the funding into, the program I know best is the Hazelden Betty Ford program, where providers, students, everyone in between can spend an immersive week there For med students, Hazelden Betty Ford pays all costs. But what if we could do something with some of our federal dollars to train up people who have a real interest in this and send them to one of the programs where they could have an immersive experience for a week to build their comfort level and their skills around this. And then next steps, which isn't always top priority. I found out recently, sometimes next steps is what's doable. One of our programs has realized that in their rural setting, they can't always get all the docs to be and providers to get their waivers, their X waivers. So they're trying to look at other things like certificate programs or more longitudinal experiences that could combine maybe CME together with some of the waiver training so that your people have a more attractive package so that when they finish a certificate, they feel that they have the skills to do the work. So I know we're talking about medical student education at this point, but we ended up talking a lot about the workforce development you need to train the students to do the work. And in a lot of our institutions, there's not enough of us old faculty people around to teach the students how to do the work.
Very good, and you're absolutely right. And even ACOM is, I recognize that we need to be kind of getting students interested and involved before they kind of even know that there's an addiction medicine specialty available and in growing interest. And so that's just tantamount to really moving this all forward. So thanks, Fred.
Yeah, and Stephen, I was just going to add, it still amazes me how many physicians don't know there are treatments for alcohol use disorder or opioid use disorder or whatever. They just don't, it just was not part of their training, so it's not on their radar. Yeah.
All right, very good. Group 4, someone.
Yeah, group 4 was small but mighty. Or myself, Josh, and Joanna. I think, and we haven't put anything in, I guess we should put something in. I may have failed as a facilitator to be a taskmaster because we just really had a couple of folks and we wanted to adjust to meet their needs. But maybe I could ask Joanna to maybe just summarize her thoughts and Josh as well, and then I'll be happy to add mine, and Norm could pretty quickly, I think.
Sure. So we did go off the rails a little bit, but we did talk about using LCME requirements and interprofessional collaboration to help integrate that addiction medicine into all different levels, whether that's student or resident education. And then one challenge is just pushback from leadership in general. One thing that national organizations can do to help us get that training into the curriculum is to just collect data on national medical school training in addiction medicine, to present that to the leadership of the school to kind of support and argue for integration. As we know, people tend to follow what other schools are doing, so that could be a strong argument for integrating that if other medical schools are doing that. And then top priorities would be to find ways to engage students based on their specific interests. So like, for example, if a student's interested in surgery, we could come at it from an angle of opiate prescription following surgical procedures. So just kind of figuring out different ways to make it relevant to students no matter what their interests are. And then taking the students who already kind of have that innate interest more specifically in addiction medicine and giving them opportunities to engage more.
Thanks, Joanna. Maybe if you don't mind typing a couple of those things in the chat so we feel like we've met our obligation. Josh, we'll leave it, we'll hear from you, reflections.
Yeah, I mean, I think I'm probably one of the reasons our group went off the rails because so we are essentially trying to really go to one extreme. We're kind of building, we're in the process of building a full curriculum for the med students here, kind of longitudinally, along with Tony Miller, who's on the call. Hi, Tony. Here at the University of Iowa. So I was really just kind of picking Bud's brain on ideas ideas he had, being kind of on the leadership side of things and how we could kind of present it to our leadership here at the university. And then he mentioned some other specifics that Joanna brought up. So.
Yeah, and actually, you know, we're here, as I think Jen said at the beginning, we're not here with our own agenda. We're here to meet your needs. And I think, you know, in general, the Iowa group, I just want to call out both the people I met. Joanna, you know, with Fred as a great role model and mentor, I think getting students interested, it reminds me how when you have a passionate leader, they can make a big difference, and one person can make a difference. And it's apparent, Fred, you're doing that. So I applaud that completely. You know, coming back to the curricular element, I think what I was impressed in talking to Josh and where he's at is that he's got a number of colleagues. So he's already building a network with Anthony and others. And that gives you great opportunity. And I think what I came away with, if you can organize yourself from a central curricular standpoint, the deans and the committees, at least at our place, they want to get down to things like learning objectives. So what are you trying to teach? Why is it important? How are you going to do it in a way that's efficient, that will fit into our curriculum? And then how are you going to assess it? And that's an important part. And I think one way to approach this, we do have the choir here, a little bit of people who are already interested, but if you can go back to your medical schools and ask yourself, what do we think is the minimal amount of knowledge, skills, and attitudes that someone needs to graduate from our school? And do we feel comfortable sending someone out and saying that they've graduated from our allopathic or osteopathic program if they haven't met some very basic requirements? And so every single area, no matter what field of medicine you're going to pursue, has relevant areas, and those are opportunities. We talked about whether you're going to be an orthopedic surgeon, neurologist, psychiatrist, family physician, internist, they're all parts of that become very relevant. So trying to make it relevant and say that anyone we graduate from our medical school has to know how to do some very basics, the very basics that we talk about at COPE, which is to be able to see a patient, be able to do some basic screening, to understand some of the red flags, to know how to refer, or if you're not comfortable, how to do some brief interventions on the front lines, and how to manage pain, which is so important, and how to do that safely. And the last thing I would say is there's great opportunities in looking at the current events, right? So you've got the pandemic, which certainly intersects with addiction medicine. We've seen huge increases in that. You've got chronic opioid use in the communities. We heard some of the stats around that. So we've got health disparities. We've got emphasis, at least in our place, on diversity and inclusion and anti-racism. All those are opportunities because it intersects with social determinants of health. It intersects with addiction problems, which occur more commonly based on some of the social determinants of health. And COVID is, as we've seen, is affecting disadvantaged communities. So if you can make it relevant to what's going on and get out there in front, when you give the talk on COVID and the community, you can interject parts that are relevant around addiction medicine. Norm, anything else you want to add? I think you're muted, Norm.
Sorry. Yeah, I not really too much more to add. It was, I thought it was a good discussion, and both of them are thinking and involved and looking ahead.
I want to make
Very
sure
good.
you know that Norm is also a COPE board member.
Thanks, Bud and all. Josh and Anthony, I will tell you, I had a meeting with Jason Barker the other day about waiver training at the school, and so I know that they're you guys are working on that and how to make it more relevant in your school and in your curriculum was one of the things that Jason was most interested in setting up the call. So group 5, if we have a report from group 5. Someone?
It's Bruce. There you are, Bruce.
Yeah, okay. So 2 of our members, Doug and Angeline, had to leave early. Samantha took some excellent notes. So I'm going to rely on Samantha and Jennifer to kind of backfill what I missed, which is probably most of it. But our top successes, integrating COPE curriculum into medical education and increasing student exposure. And I think that's coming from UMKC, as I recall. And engaging more medical students in Missouri. I think that the Department of Mental Health has an initiative to engage medical students, and they've had some success and some resistance and some challenges. So more to do there. The PCSS medical student training course, that is what? Anybody good with that?
It's the provider clinical support system, and it's a SAMHSA funded program primarily around looking at opioid use disorders. They're now moving into amphetamines because of what we heard in the opening.
And I'll add, there is one that is specific for opioid use disorders, and there's also one specific for serious mental illness. So there's 2 of those, important to know.
Great.
And a lot of good info as well with chronic pain and interactions with both of the above.
One of the other challenges we have listed here, which is really the one that we encounter, and I think others have to a certain extent as well, and that is the culture. You can you can teach medical students, but if their attendings, their mentors don't buy it, then it doesn't take. So that is, I think, and that culture still exists to a great extent. It's better than it used to be, largely thanks to the huge Asper initiative that many institutions have had, but they've had grants, but it's still a big deal. The top challenge that we talked about was navigating medical school administration and bureaucracy. Here we call it the mother of all bureaucracies because it is just seems to be infinitely complex and it's very lateral as opposed to vertically integrated. So yeah, each department is kind of its own thing. And so dealing with that is a challenge. And changing the culture is again a big challenge. Support, we talked about ways to connect champions and advocates across the region, the state, through listserv, because we're kind of all operating in our own little bubbles and we can get pretty lonely. So finding ways to connect us and for support and encouragement, ideas. Action steps, incorporating into existing curriculum rather than adding. I think the term was insinuating into curriculum was something that is a good concept that we can all take home. And importantly, not just focusing on medical education, but also resident and faculty education, because once again, you can't approach this, we don't think you can approach this just by teaching medical students. You have to teach everybody. So Jennifer, Samantha, what did I miss?
Samantha, why don't you go first and see what you've got.
Oh, sure. So I agree with everything said. I think just from the student perspective, just to add in terms of adding to the success, I do think that having the students engage with these topics in real life, in person, rather than just discussing it through a journal club or reading an article is a lot more impactful. So just kind of to summarize again what I said to the group, as part of SLU's clinical interviewing course, we were required to like go to an actual support center in the community and meet some of these individuals who were in recovery or recovering, and see how some of them have really changed their lives around and are helping to run these centers. So seeing how invaluable that these community clinics or services are, and meeting these folks. So certainly that was, it informed my decision to get more involved. And I think that that's definitely to add to the success of what certain schools are doing right.
Thank you. Great synopsis. I just have a couple of things to add. I think in listening to what people had to say, I was struck really mostly by two things. One was the challenge that we face with a generation of attendings who did not grow up with this knowledge, skills, or attitudes, and what I think is being referred to as culture change. And that is in my role at the University of New England College of Osteopathic Medicine. I find that that is one of the biggest hurdles that rising physicians, students are finding, because they have learned how to talk about substance use disorder as a chronic disease, and yet they're meeting, it's a clash that they're running into. So we're trying to figure out, how do we teach them how to speak truth to power, and in a respectful and non-confrontational way. It's very challenging. So I think I just wanted to build on that a little bit for you. And the other, or for myself, I guess, really. And the other thing that really jumped out at me was the emphasis on champions. And Kim, you have done a wonderful job bringing these folks together. It's just really, really key, finding that as someone who has a PCSS university grant, that my fear is when I go away, which I will do soon, from the University of New England COM, that all this work will disappear. So we need to have not only champions, but also some sort of succession plan. And in COPE, and Steve, I might just kick this back to you. In COPE, this is something that we've talked about for a long time, as kind of almost, pardon the expression, holy grail for us. Mm-hmm. If we could have a person in every school. Steve, do you want to build on that a little bit?
That's really just to reiterate what you're saying, that the importance of having a champion at the school is just, we've heard it in multiple ways today. It's just so important to actually moving this work forward. And in part, that person needs to not only be looking at the curriculum, but it needs to be, having discussions with people in various specialty areas, and trying to build that culture, trying to establish that, we see these folks in every area of medicine. I was thinking of that in terms of, I think what Amanda said, like in terms of opiates and surgery, but where one of the things that came up with my, talking to the surgical residents was around alcohol and trauma associated with alcohol. And so it really, you just don't know how it's going to happen. But if there's someone there that just keeps talking about it with the various areas of medicine, you can start to build some momentum, and it can become a very, very powerful aspect of student training. So find a champion, look for that champion. If you're a student, look for the champion. If you're a curriculum developer, look for the champion. We're looking for champions all the time. So,
and if you want to be one of those, tell us. And
yeah, right.
I loved the idea of the listserv. I'm not sure whose idea that was. Somebody want to raise their hand if that came from, was that from your group, Andrew, or no? Or in any case, I thought it was a great idea. So that might be something that we can work on.
Very good.
Yeah.
So next steps, Jen?
Next steps for us are to make sure that you get all of the materials from the meeting, everything that we said and talked about. Then we will talk with Kim and see how we can proceed in working in Region 7, which is, wow. You folks in the Midwest are rocking this in a lot of ways. So another thing that we do at COPE is we share across the country what we find in these regions. So some of you might find yourselves contacted by other folks in other regions just because we know what's going on. And so also we're going to ask you to do an evaluation, and then we'll share the results of that as well. Cammie's going to go ahead and put the link to that evaluation in the chat. And so while we're kind of wrapping up here, you can take it. It's very brief. We just really want to find out, there it is. Thank you, Cammie. What we can do better, what you thought was the best part. And like I said, this is only our second Zoom rodeo. We've done a number of meetings around the country in the past. However, I don't believe we've ever been to Region 7 before. So this is all very kind of new. We're finding our way. We need you to tell us how we can support you and how we can support the region where there's so much need, as Kim pointed out to us. So if you would please click on that, and while we're chatting and finishing up, if you could fill that out. I'm Kim and Bud and Tony and Steve. I'm going to leave this up to you to kind of say some last words and how you, whatever you.
One thing, because it is so important to bring in other organizations, I would just wonder if either Lisa or Tyler have, heard things or ways, the things that they feel now they want to say, since they kind of started the meeting, but if there's things from AAMC or ACOM that, and if not, we can move on, but I just wanted to make sure that they had an opportunity. There's Lisa. You're on mute, maybe.
About that, I had a external, can you hear me now?
Yes.
Yes.
Thank you. Sorry about that. I had connected an external mic and then disconnected it. So no, thank you, Steve, for that. And I just, I unfortunately missed, part of the meeting. I logged back on about 10, 15 minutes ago. So, and just been listening to this, the discussion. And yeah, I would love to have, from COPE and SAMHSA kind of to be in that loop when it comes to, what was shared and discussed and especially, great exemplars and models, kind of like COPE, we're also very interested in spreading, strong models and resources. And if you're willing, there is there are a lot of educators out there who are seeking, good models, resources, and I'm sure you know that, but oftentimes, we don't hear about it as much as we would like and as frequently as we'd like. So we'd love to get that more specifics and more details, and then share that. And I'm sure, I don't want to speak for ACOM, but I'm sure my colleagues there would want to do the same. So, thank you again.
Very good. Thanks, Lisa. And I don't know if Tyler's still with us, but if Tyler wants to say anything, otherwise, Tony, Norm, Bud, any?
Yeah, I mean, I just want to thank Kim, especially for helping organize and sort of inviting us into this region. I think we learn a lot coming in here, and our goals, as we stated, are really to be a resource and partner. We're sort of a group that somewhat unique. We came together really trying to facilitate a common goal. We don't have aspirations like other organizations. We don't have a lot of we don't have dues, we don't have national meetings. We're here to try to move things forward in this field. And I would encourage people to join with COPE. And it's an organization that we're actually looking to expand and have opportunities for people who are interested in taking on some leadership roles. I think that's even on the horizon. Many of us who started COPE really goes back a number of years in terms of some of the ONDCP, the Office of National Drug Control Policy, and White House summits that have looked at education. And many of these things have had meetings and summits where the findings are sort of put on a shelf. And COPE came out of trying to keep momentum going and also facilitate a way to bring different outstanding organizations that already exist that have components of what we want to do, SAMHSA, AAAP and such, try to not compete with those groups at all, but actually help work with them. So as mentioned, I think if we end up with COPE being a sort of a central repository for champions at all the allopathic and osteopathic medical schools, that we can, facilitate communication, sharing of best practices. That's really where I think we can help all of you. So I would hope you'll stay involved if you haven't heard of COPE or been involved before, that there's an opportunity here. We want to be very inclusive, and I'm very impressed with a lot of what I heard is going on here. Really, we hadn't been to this region before, and there's so much energy in this group. It's exciting and a lot of opportunities. So please stay in touch, stay involved with COPE.
Thanks, Bud. I think that, and this really goes back to the job that Kim's doing, which is just really wonderful in kind of keeping the region discussing things, because as even the materials that she presented in her opening, there are specific problems within regions, and the schools, many of the students are going to stay in that region. A lot of the state schools, that's the goal, that they stay there. And so to know what's going on in the region, to have know some of the resources in the region, some of what Fred's doing in terms of tying it to the community, tying it into social determinants of health. These are all real important things, and they are more specific to regions. And that's one of the reasons that we started doing these meetings per SAMHSA region, just to have a smaller group of schools to come together that might have some common problems and common interests to start to look at this within their schools, look at substance use problems in general. So I don't know if there's anyone else that had thoughts. Kim?
I definitely want to chime in here and just say thank you, especially to those little over half of you who have made it the whole time. Impressive. It's a lot of time, and really value your commitment. That's what it shows, you know, the fact that you're still here and having this discussion with us. So thank you for that. Thank you to the students. You know, that culture change that we all just have to keep working and pushing at, you know, you are instrumental in helping to move that culture. And I have a lot of hope because, you know, the culture has changed. It is different than it was 10 years ago, 20 years ago, you know, and so it's going to keep changing, and you are that future. So, I just want to say thanks for all the kind of great popcorn of ideas that I heard. I especially liked that idea about funding immersion mini fellowships. So that was really insightful and great to hear about and think about, and you know, maybe talk about up at SAMHSA. We do have a little bit of funding in this space, as in substance use and mental health, and an ever increasing amount of funding right now, because, you know, it's an opportunity moment for us, those of us that have behavioral health as a passion. So anyway, you know, great ideas. I liked the idea about, you know, who's got the data on the national data on medical school curricula, you know, related to addiction medicine. A national data set about that. That was a great thought, just the continued need for culture change. And how do we get people with lived experience, you know, more insinuated, just like we talk about getting SUD curricula insinuated throughout medical school? How do we get those folks with lived experience? Because I know in my education, which was not medical school, you know, we had a woman who came and talked to us in a class who had schizophrenia and was, you know, recovering, managing that chronic condition. And that had the greatest impact on me of maybe all of the schooling, you know, that I can remember. So I know those moments of, you know, people sharing their lived experience has a huge impact. So I feel like, you know, maybe that's something, you know, we could do. I guess I'm interested in concrete things that anyone can think of that we can do in this region in addition to what we are doing. So if it's okay, we have this quarterly convening that I talked about that talks about, just keeps the discussion going about addiction medicine. And every quarter we do that. I think I ask the question, do we want to keep doing this? And I always think people are going to say, no, we don't have time. You know, quit pulling us together for this hour, you know, once a quarter. Every quarter, everyone says, yes, we want to keep doing this. Yes, we're looking forward to the next meeting. And more people come. So if it's okay, I'll send an invitation to everyone who is at this convening to join us. Bring your students, bring anyone, you know, it really is an open dialogue for an hour once a quarter. And so unless anyone objects, I'll just send you all an invitation for our next one, and we'll see where that discussion goes. So that's one thing. And the listserv. So, you know, listservs are an interesting thing, but maybe there is a way. Missouri has a, you know, very powerful opioid listserv that really is a powerhouse listserv. It's the best listserv really that I have experienced. So maybe there would be a way for us to, you know, model off of that, just some things related specifically to addiction medicine curricula. So anyway, something for us to think about. All right, well, just, yeah, really, and here's my favorite quote from the day that I will take with me. And of course it comes from Fred, who is, you know, as you've heard, quite the champion in this area. Fred, thanks again for, you know, all you do and all you did for this. Follow the directions on the easy stuff, get in trouble on the more interesting and fun stuff. So that was my takeaway quote from the day. Anyway, thanks again for you all being here. Jen, turn it back over to you.
Thank you, Kim. You have the last word. Thank you, everyone, for coming and for all you're doing for our country and our people. It's lovely to meet you all. Just see you soon.
Yep. Thank you so much.
Thank you, Kim,
Thank you.
for your leadership.
Bye-bye.
Bye-bye.
Hey now. Well, great meeting.
Great.
Wow.
Great
Yeah.
stuff.
Oh, we lost Steve. Maybe he'll come back.
It was so great to, have 36 people logged on at the height of the numbers and only down to 20 by the end. That's not too bad, I don't think.
Bad for a 3-hour meeting. You're
For a
absolutely
busy group of people. Yeah.
Yep. Should we, I imagine everybody's pretty fried. I want to thank you all for all your efforts. I mean, there was quite a bit of preparation. Ken, your session was fabulous. You're just laying the groundwork. Wow. It really helps steer us in the right direction.
Well, I think, you did the yeoman's work, especially in my last couple days drop off. So I appreciate all your heavy lift of, making this happen.
I couldn't bring you a casserole. So if we were neighbors, that's what I would have done.
I feel the virtual casserole.
Thanks, Jen. We're really trying through the details. Thanks so much.
Presentation, great facilitation. Yeah. Wonderful.
Appreciate it.
Cammie, you saved our bacon. Great work. Excellent work. And Norm, we'll talk about this at some point as we get ready for Region 2.
All right, great. I'm going to let you all go, and I'm going to go to the dog park and walk.
Yeah. All right. Take
Beautiful
care.
outside. Okay, take care.
Thanks again, Kim. We'll talk soon.
Thank you. Yeah.
Bye.